Our second speaker this morning is Dr. Mary Magarey. And Mary Magarey is a specialist musculoskeletal and sports physiotherapist. She's a senior lecturer in the School of Health Sciences at the University of South Australia, where her primary responsibility is classroom, laboratory and clinical education on the Masters of Musculoskeletal and Sports Physiotherapy program. Mary completed her PhD in shoulder diagnosis in 1999 and has been involved in research, education and clinical practice relating to the shoulder for more than 20 years. She was awarded her fellowship in musculoskeletal physiotherapy in 2009 and was awarded her fellowship in sports physiotherapy last night. Congratulations. Mary also runs a small consultant specialist practice where the majority of her work is with patients presenting with shoulder disorders. So, Mary will talk to us this morning on rotator cuff and degenerative tendinopathy models. How well does it fit? And how does consideration of the model affect management? Mary.
Thank you, Peter, and thank you for inviting me to present at this conference. And well done to all of you for getting up at this time of the morning. I'm presenting today in the role of a clinician who is trying to use the evidence to inform my clinical practice. This is not research-based, this is suggestions for how we can look at what's out there and adapt it to another area of the body. So it's going back a year or two. In 2008, Jill Cook and Craig Purdom in the British Journal of Sports Medicine proposed that the various types of tendinopathies that we have been recognising over the years may well form part of a continuum. And they proposed this model where they started with normal tendon in the middle. If you have normal tendon in the middle and you provide it with an optimal load, it will adapt, and then it will improve the strength of that tendon. But in some areas of tendons, and in some tendons more than others, there are areas where tendons become underloaded or stress shielded, particularly the deep surface of tendons that turn corners. So if you have a tendon that is unloaded, then it may become stress shielded. If you can load that tendon appropriately, it will eventually come back to being normal. But if that stress shielded or unloaded tendon is then excessively loaded, and there are factors associated with you as an individual, you may end up developing a reactive tendinopathy. With that reactive tendinopathy, if you modify the load appropriately, it can settle and go back to being a normal tendon. Equally, if you have a normal tendon that you overload excessively, and there are factors associated with you and your makeup that make it relevant for you, then you can develop a reactive tendinopathy. You manage that load appropriately, that can go back to being normal. But if you don't, if you ignore this and you keep on loading it, then there's a chance that that reactive tendinopathy, according to Jill and Craig's model, will develop into a tendon disrepair. And with a tendon disrepair, there's more disruption of the tendon structure, and you can still, by adapting your load, end up getting back to normal tendon, but it's a little bit less likely. If you continue to ignore that tendon and you continue to load it, it can end up to the point where you have a degenerative tendinopathy. By the time you've got a degenerative tendinopathy, there is very little chance that even appropriately modifying the load, you will actually change the structure of that tendon. This, remember, is a model. It's a hypothesis. So if we look at this, what happens in these tendons when you get a degenerative tendinopathy? We're only going to talk about the degenerative end of the tendinopathy spectrum for today. You get a progression of the matrix and cell changes from the disrepair phase, such that there are areas of cell death from apoptosis, trauma or tenocyte exhaustion. There are areas of acellularity, and the very large areas in the tendon of disordered matrix filled with vessels, matrix breakdown products, and very little collagen. And once you get to this point, there is little capacity for reversibility of these pathological changes. Considerable heterogeneity of the matrix and islands of degenerative tendinopathy interspersed between other stages of pathology and normal tendon. What do these things look like clinically? Well, they can occur in young athletes who chronically overload their tendons, so the young elite athletes, and the ones that Jill and Craig talk about mostly are jumping athletes, and they're thinking about lower limb tendons. But typically they occur in a middle-aged recreational athlete who develops focal tendon swelling and pain. There are often a potential history of repeated bouts of tendon pain that settles with rest and then reappears when you re-add that load. And these tendons may rupture under high load, or they may rupture if the changes to their load are extensive enough. So we know that 97% of ruptured tendons have degenerative change. Normal tendon doesn't rupture, it's way too strong, as we've just heard. So what about the rotator cuff? Where does the rotator cuff fit into this tendinopathy continuum, or can it fit into the tendinopathy continuum? I've talked to Jill Cook over many years, and she's always said the rotator cuff's different, it's too hard, we can't think about that. Well, maybe we can. And Jeremy Lewis is a researcher from England. He's an Australian physiotherapist who did his training, well, he's a New Zealander, but we'll excuse him for that. Did his training here in Australia, and he's now working in England as a researcher and clinician. And he's adapted the Cook and Purdom tendinopathy model for the rotator cuff, looking at, in the same way as we have with the other tendons, that you can start off with normal tendon and it can go through the same set of pathways. So if it's underloaded because it's in a stress shielded position, if you load that up and you do it in an appropriate way with an appropriate amount of load, it can go back to being normal. If you overload it too far, you will end up with a reactive tendinopathy. Sorry, that's in the middle there. You end up with a reactive tendinopathy. And because the tendinopathy is there, and we'll talk a bit more why, you end up often with bursal involvement as well. And if you unload this and change your load appropriately in the same way as we said for other tendons, it can go back to being normal. If you don't, you get to the tendon disrepair stage, just the same principle as we had with the other model, again probably with some bursal involvement. And because particularly the supraspinatus tendon is a pretty large tendon, there are quite likely to be elements within that tendon that are still demonstrating reactive tendinopathy stages. And that stage, you've still got the chance of it returning to normal, but that chance is getting less. If you overload it further, then you get to the stage of having a degenerative tendon with a degenerative tendinopathy with all the same sorts of issues. So this is Jeremy's hypothesis. And how do we know whether that will fit or not? Well, there is evidence from the research, from the basic science research, that there are diffuse degenerative changes in the rotator cuff tendons that include things like tendon thinning, fibre disorientation, degeneration, calcification, fatty infiltration, and vascular proliferation. Sounds pretty much like what we were talking about before from the lower limb tendons. These changes are more pronounced in the deeper layers, except for the fat infiltration and the neovascularization. And in painful and degenerate tendons, there are increases in type 3 collagen, which reduces the strength of the collagen. There is increased presence of pro-inflammatory cytokines and increased presence of apoptosis, and ingrowth of neovessels and disruption of your tendon structure. Again, sounds very much like what we've just heard about. So what about subacromial impingement? Subacromial impingement has always been told to us as this is the primary pathology. Since Charles Neer in 1972, subacromial impingement is considered the primary pathology in the superior shoulder. Ben Kibler did say at this equivalent conference 2 years ago that it would take a whole generation of orthopaedic surgeons to die out before that hypothesis died with them. But Soslowski and company have done a series of experiments looking at the relationship between these things in some little rats. And first off, they wrapped something around their acromion to make it appear like a type 3 acromion. And then they let the rats run around and do their normal thing. And then they looked at them, and what they found was that didn't produce any changes in the bursa or any changes in the tendon. Those rats just appeared to be normal. Then they took a second group of rats and they put them on a treadmill and they made them run and run and run and run and run and run some more. And then they sacrificed those rats and they looked at their tendons and they found there was an increase in the cross-sectional area and a reduction in their maximal strain, very much like in a reactive tendinopathy in a human. So that's fine. The tendons react no overload, the tendons don't react. So then they wrapped something about the acromion on another group of rats and put them on the treadmill and make them run and run and run. And when they looked at them, they had the same changes as in the running rats, but even more so. So the conclusion from this is that an acromial spur or something equivalent is probably insufficient to cause impingement on its own without an associated overload on the tendons. So the tendons are likely to be the primary problem, with the reaction in the bursa being secondary. But what do we know about the bursa? Well, we do know there's a strong positive correlation between shoulder pain and the amount of pro-inflammatory cytokines and pain chemicals within that bursal tissue, such that patients who have night pain and constant pain have more inflammatory markers in the bursa than those who only have pain on movement. However, so that sort of make you thinking, well, this is a subacromial bursitis, that's where we start, it's an impingement problem. But bursae have been strongly demonstrated to be strongly linked to tendinopathies in other regions of the body. The retrocarcaneal bursa is very closely associated with the Achilles tendon, and pathology occurs in both. Same for the intrapatellar bursa and the patella tendons, and the trochanteric bursa and the glute med and min tendons. So, is this part of an enthesis organ concept? Is the subacromial bursal pathology part of an enthesis organ concept, the same as it is with the bursae associated with those other tendons? And I wrote to Michael Benjamin after hearing him talk at a Sports Medicine Australia conference a few years ago and asked him that question. He said, Michael Benjamin is the person that's done all the enthesis organ research. And I asked him the question and he said, they haven't done the research on it, but it kind of makes sense. So that the rotator cuff may in fact function, the whole thing may function like a double enthesis organ with the articular surface of the tendon and the bone underneath, and then your coracoacromial arch with your subacromial bursa underneath. But he didn't know. So moving on to management, because we don't have time to get through everything, we know from Jill and Craig's work that management of tendinopathy is all about management of load. And management of load depends on your biomechanics as much as anything. So if we think just about the tendon disrepair group, and we look about what's involved with that, if you want to manage load, you need to also manage pain. And to manage pain, we need to try to reduce the swelling in the tendon, because the swelling in the tendon is what's going to cause secondary problems in the bursa, or it may be. So we can do things like tape these shoulders to support them. We can ensure that they've got adequate range of movement. We can lengthen the cuff muscles. And if you listen to Jill Cook, she's talking these days about it's not appropriate to stretch these from a not the way that Eric was talking about, from a performance enhancing and injury prevention point of view, but when they are already in a pathological state. You are better to stretch the muscles by getting in there with soft tissue techniques on the muscle rather than doing a traditional stretch on the tendon. So you stretch the tendon, you actually increase the internal compressive forces within the tendon. So we can look at lengthening the cuff muscles without actually stretching them, and we can look at facilitating dynamic stabilizing function of your rotator cuff. So what I'm going to present from here is just one way that we can go about it. There's no research associated with this. I'm drawing on basic principles and putting it into a clinical context. And as we heard the other day, there's more than one way to skin a cat. This is just one option of your cat skinning exercise. So we can use supportive taping, and this isn't anything fancy. It's just a tape that draws the humeral head up into the glenoid, tries to facilitate a bit of cuff function, and just gives it some support. And if you speak to Melissa Locke earlier in the week, she will tell you that it can certainly help with pain relief. We can look at joint mobilization without that tendon compression force. And I really like this position of the classic Maitland position of the glenohumeral quadrant, but in prone, and if necessary with pillows under the tummy so they're not quite so far in end range. Because what I can do with my hands in that position is work stretching the capsule in a position where my hands are very close to the joint. I can feel for spasm, I can feel for tissue resistance, and I can do that in a nice controlled way without putting any torsional force through any bones. And we can work through the tendons, through the muscle bellies with soft tissue techniques, with a variety of different techniques, and there is research to demonstrate that that can increase your range of internal rotation. There are many ways you can look at training dynamic control of the humeral head. and Tanya Pizzari told us the way that she and I've gone blank anyway, the way that they can do that, they've been doing it with the research she reported the other day. This is a technique that we've been using for a long time that's based on the same premises, training and transversus abdominis or your craniocervical flexors, where Mark takes much better photos than me, so I try to get him in the photographs instead of me. But what he's doing here, he's got his fingertips on the tendon of subscapularis in the armpit, and he's got his thumb that you can't see on the tendon of infraspinatus posteriorly. So that what he's trying to stimulate is the transverse force couple that is responsible for holding the humeral head in the glenoid. What Mark's then doing is, if I can find my mouse, giving a very gentle traction on the arm. Now you have to explain this concept to your patient first. Traction on the arm and asking her to draw the humerus back up into the socket. Trying to use relatively isolated contraction of those two muscles and not over all the global muscles as well. So that's one way you can do it, and if you've got a very dysfunctional cuff, it's the way we've found is most useful to start. But you don't have to take everybody back that far to retrain their dynamic control of their rotator cuff, and as I said, there are obviously other ways of doing it. With this one, what we're doing is using the premise that the humeral head should stay centered in the glenoid when you activate the rotator cuff in a rotary direction, not thinking about it in specific co-contraction. And you can do this evaluating the arm in different positions of elevation, looking at it first isometrically in both directions and then isotonically in both directions, feeling for the humeral head to shift, or feeling for there to be a change in the quality of contraction under your hand, or feeling for there to be provocation of crepitus or pain. And then when you find that, you can then work backwards from that to a position where they have control and they don't get that crepitus or pain, and that's where you start your training from. Equally, on the basis of more work by Jeremy Lewis, where they're looking at rotator cuffs with massive tears, they used a model of a modified closed kinetic chain program. We're using a resistance through the hand, working first off with the bed flat, getting these patients to punch right forwards into full protraction and external rotation, because that facilitates the trapezius serratus force couple that you want in the scapula. Punching right forwards through there and then coming back under that load, gradually increasing the height of the bed so that you're gradually getting into more and more elevation. And when you're up there, you can get them to do little circles, figures of 8, elevation, depression, extension, side-to-side movements, gradually increasing how much they can control and increasing how much load you put through their hand, always working from a short lever until they've got good control. Now we know from the work in the lower limb that tendons like load, but they like load if you apply it slowly, or if you apply it so that the tendon can adapt slowly. Jill's comment was tendons like you to get up in the morning and do exactly the same thing that you did the day before. So if you want your tendons to do more than that, you don't go out and belt the hell out of them. What you do is to add load slowly and progressively. And you can do that in positions where avoid subacromial impingement. We know that external rotation reduces the compression through your subacromial space and internal rotation increases it. So we need to look at positions to train these muscles that are going to avoid that impingement. And it makes sense in that case to start by training your external rotators and bring your internal rotators in later when they've got a bit more control and they can hold their humeral head in position. So this is a position that's been demonstrated in the EMG literature to activate all your external rotators and your scapular retractors to a maximum. So it's a position where you're working into external rotation inside lying. The thing that we can do to adapt that, to avoid the subacromial compression, is by blocking the movement into internal rotation with your own hand. So that what Jess is doing is just coming down and resting her hand onto her other hand and then going from there up into whatever range of external rotation she's got. She's resting her arm on the towel and we're trying to make sure that she's spinning like a chicken on a spit through the axis of her humerus. And you can turn that into an eccentric exercise if you want by getting them to push up with the other hand, let it go, and then they just do the eccentric component of that part of that movement. So then if we consider the degenerative tendon rather than the tendon disrepair, We know in these ones that pain control and restoration of normal movement is really important, and all the management options that we've just talked about with tendon disrepair are also relevant for a degenerative tendon. And there is research that demonstrates that even in the presence of substantial structural pathology, range and power can be improved if you reduce the pain. You may not necessarily get a beautiful movement, but you can certainly get them functional. So assuming that we've been able to work through the things that we've just talked about, you can progress your strengthening of the rotator cuff, provided they can do it maintaining control of their humeral head in the glenoid. Prone, working in scapular retraction, will also activate your external rotators very strongly. So that can be a nice progression of doing the side lying stuff and gradually adding a weight to the hand. If you're talking about dealing with athletes, you can make it even more significant by getting them to work that in conjunction with activating their thoracic extensors and their scapular retractors and their whole kinetic chain by working against a ball with a little weighted ball in the hand. And this is an exercise that we've been using for a long time for scapular upward rotation, but it actually works really nicely to strengthen your internal rotators as well. What Jess is doing there is a modified push-up plus position, but we're doing it with the TheraBand because what that does is it allows you to stay in external rotation, so you make sure you've got the right scapular pattern. The little bit of yellow TheraBand between her fingers here is a cue like the TheraBand you wrap around people's knees when you want them not to adduct when they're doing a squat. It's just a visual cue and a tactile cue to make sure she doesn't drop her thumbs in and her elbows out and go out like that. She has to stay in that nice external rotation pattern. If her thumbs drop in, the TheraBand goes slack and it reminds her to move differently. You can also integrate that internal rotation training in non-impingement positions by going from external rotation to neutral rather than just from here into your side. And obviously once they get good enough, you can put it into a push-up plus type position where she's doing a push-up and then pushing right through into maximum protraction. It's important that we address the contributing factors here as well as it is in the tendon disrepair. And a lot of shoulders, particularly the degenerative ones, have an element of cervical somatic referral. And when you've got cervical somatic referral for a shoulder problem, you don't have cervical signs. You won't have cervical active movement limitation. You won't have pain in the neck. You won't have pain coming from the neck to the shoulder. But what you do find is that these patients have a degree of grumbling irritability and a low constant ache. And what you find on your examination is that their accessory movement, usually at C5-6 or C4-5 in the PIV joints, is restricted on that side and not on the other side and locally painful. If you treat that accessory movement dysfunction, you can often get rid of that grumbling irritability and increase their range of movement, and then you can focus on treating the shoulder. These patients often also have neurodynamic involvement, either restriction of range or provocation of their shoulder pain on neurodynamic testing. And so we can mobilise the neurodynamic structures with whichever technique is appropriate. And Michelle Capetius was telling us the other day that the sliding techniques are more effective if what you're looking for is movement than a stretching technique. Equally, I don't think I would see a degenerative type tendinopathy that doesn't have a stiff thoracic spine. So you need to get in there and mobilise that with exercises or with your passive mobilisations. And how you do that depends really on the age and the osteoporotic status of your patient. So this is what Ben Kibler talks about as the non-shoulder shoulder assessment. So my wonderful friend and colleague Barb Darwood volunteered to act as my older shoulder patient here. What she's doing is a nice lot of bows and arrow type exercises, really aiming at thoracic mobility, because if you can increase your rotary mobility of the thoracic spine, you will also get some increase in your extensor mobility. And if you're thinking about older people who may be a bit osteoporotic, that's a much safer way of doing it. And at the same time, you're getting quite nice shoulder and scapular movement. Equally, we can consider upper thoracic extensor activation. And I smiled when I saw what Sean told us about what he was doing with his low cervical extensors, because really the upper thoracic is only a couple of levels further down. And without knowing the way that he had been activating his, what we're doing is something reasonably similar, but with probably much less science behind it. So what Barb's doing here is it's a little bit like your craniocervical flexion position, but I just find that these patients who don't have cervical pathology, you don't need to go back quite that far. She's got a little towel behind her head and she's using the cue of lifting her sternum to try to get relative isolated activity through your upper thoracic spine. Now, if she's stiff, like most of these patients are, you don't get a lot of movement, but you can get a sense of activation in those muscles. Also, doing this over a Swiss ball can be quite nice because you can keep their knees on the floor. Most of these people, if you ask them to extend through their thoracic spine, will extend through their thoracolumbar junction. So you get them to tuck their pubic bone into the ball, and then they can push themselves up if they need to, or if not, they can use, again, that lifting the sternum notch as a cue. And I've just not in the photograph because it didn't work, but I also will walk my fingers down the thoracic spinous processes to encourage them to lift segment by segment. Oops, go backwards one, sorry. Same way that we talked about for the the disrepair tendons, we can look at decreased scapular mobility, we can mobilise for that, glenohumeral tightness and muscular tightness in exactly the same way we did. We also need to look at improving scapular muscle function because you cannot have a functioning shoulder without having a functioning scapula. And for this we've been using a very bastardised form of PNF because I was told when I was doing my MNIPS course that I couldn't do PNF, I was hopeless. So what I'm doing is apologies to the PNF people, but also facilitation of upward rotation inside lying and then transferring that into a home program. So this is my attempt at some form of PNF, doing an up and forwards and down and back pattern, and up and back and down and forwards pattern. So that's the up and forwards and down and back. But then looking at this upward rotation facilitation, where with whatever load you want to put through that arm, depending on how much pain the shoulder's got, most of my facilitation and load is through the lateral border of her scapula, trying to stimulate upward rotation. And they respond really well to this tactile stimulation because without it, you don't really know where your scapula is in space. So don't forget that we can also improve the mobility of the subacromial bursa with a whole heap of mobilising, and we can talk about that later, running out of time, because the other thing I really wanted to mention is that there is a lot of evidence now for upper limb tendons as well as lower limb tendons to demonstrate that adiposity, specifically in the, around your midriff for men and around your hips for women, will increase the risk of tendinopathy of the shoulder, of your rotator cuff. And we are ideally placed as professionals to consider that addressing those general factors. We heard all about that yesterday, and I think it's a really important part of our role. Also, there's a very high correlation between rotator cuff pathology and smoking, and there are a lot of surgeons around who will not operate on smokers for their rotator cuff because they get such poor results. Again, we're ideally placed to start to put that thought into patients' minds about how they can manage to address the smoking issues and strategies to help them give up, and obviously refer them on to the right people. We also know that, as we've heard a lot this week, about psychosocial factors that are associated with anxiety, associated with a lack of information about what's wrong, and that can lead to a degree of central sensitisation. And we've heard all week about how it's our role to be able to address that, and I think it's a very important part of what we do, not just treating the local structures, but everything else. And along with that, establishing collaborative goals for assessment and management with your patient, because empowering the patient to take control of their pain will have as much effect as anything else that we do. So thank you for listening, and I hope that you can take those ideas away and mull over them, and in a few years somebody will do the research to see whether I'm right or not. Thank you very much.
Thank you. Do we have any questions? Oh, right there. Now that's perfect timing.
You mentioned that bursitis is sort of considered to be part of tendon degeneration.
Yes.
Seems quite
Can't
well
see where
accepted.
the question's coming from, sorry.
Up this side, Mary.
Which
right
side
up
is this
yep.
side?
Up here, right up the back.
Okay, thank you.
It seems quite well accepted that corticosteroid therapy is not helpful in tendon degeneration. So what is your thoughts in regards to bursitis?
There is a lot of research out there about the use of subacromial injections and their effectiveness. Jeremy Lewis's hypothesis with that is that if you have the night pain, if you have constant pain in the shoulder, then a subacromial injection is with corticosteroid is likely to be effective because you're going to change, or you have the potential to change the presence of those pro-inflammatory cytokines. You don't inject it into the tendon, obviously, you inject it into the bursa. But if you've not got constant pain or night pain, then his hypothesis is that maybe what we should do is just to inject a local anaesthetic into that bursa, or maybe even just needle it, so that you're just changing the mechanical input and using some sort of gating response rather than adding the cortisone to it. So there's a lot, I haven't got into it today, but there's quite a lot of research to demonstrate that physiotherapy is as effective as subacromial injections, physiotherapy including mobilisation and exercises, and that we're just as good as surgery at a 2-year follow-up. So, yeah, I would, if you've got a patient who's got a really painful shoulder and you're just not being able to get the activation of the muscles going, what I would do is to send them off for an injection as a trial to see whether if you can settle the pain from the bursa, you can then get better activation of the muscles.
Following on from that, we have a question up the back. Mary.
Mary, what exactly would you do to mobilise the bursa?
To mobilise, oh yes, I had to skip over that. Thank you for the question. If you've got a really painful bursal subacromial type situation, then I would start, I'm very Maitland trained, so I would start with gentle passive movements of the shoulder where you're effectively moving the glenohumeral joint against that bursa and just encouraging some movement, but in a pain-free way. Once they've settled from that, I'd put them back up into that quadrant position, and I do tend to do it in prone because I've got more control and you get better relaxation. And you can actually mobilise the humeral head adjacent to the acromion with and without compression. Initially, you would do it without. When that stops being effective, you can add compression. Now, I've had people get really upset at the idea that you might mobilise the subacromial bursa under compression because that seems completely wrong. But we get in there and we friction things, and we can decrease the pain from frictions, even if we don't understand exactly why it works. If we stand on the safe side of Jeff's brick wall, for those of you that were listening to Pat 2 days ago now, we don't quite know why it works, but you mobilise that bursa under compression, it does seem to get better. So maybe what we're doing is breaking the fibrous bands that run north-south that you see when you look at them under arthroscopy, but it can be quite effective.
Okay, one last question from the floor.
Thanks, Mary, for a great talk. I'm just wondering, do you ask patients about whether they're on statins? Because there's increasing evidence that statins, I know you're looking a bit, but actually statins actually cause, I'm up here, Mary.
Over this way. Okay.
Statins actually cause increased tendinopathy. So I wondered whether you then talk to them about going back to their GP and perhaps getting a different sort of medication.
Yep.
Certainly having a heart attack's a bit worse than having a tendinopathy, but...
Yes, I haven't, I certainly do. I haven't had very many that's been the situation, but thank you for bringing it up. It is a really important point.
Thank you.